Good afternoon to you all. My name is Dr. Kakame. I'm a first year SHO, internal medicine. Today we are talking about the kidneys. Kidneys are very important. Kidneys, on average, the kidneys excrete 200 liters of blood in a day. That makes them very important. And green is our color, so the pastures are green. And just to mention that March is our month. And I will start with this patient called M.A., who is a 17-year-old male from Mukono. He was a casual laborer working on a farm. He presented to us in Chirudu National Referral Hospital with a history of fever for a week, dyspnea for 3 days, and mentation for 2 days. So M.A. was well until a week prior to admission, when it involved high-grade fevers associated with chills and rigors, with cough. He went to a nearby drug shop, self-medicated with Coartem and paracetamol, as is common. Unfortunately, the symptoms worsened. 4 days later, he involved worsening dyspnea that was worse on exertion. This was not associated with orthopnea, no lower limb swelling, and no chest pain. This again progressed further. He became very, very weak, developed headache, and developed also mentation, and was quickly rushed to a nearby health facility where he was diagnosed and treated for severe malaria. They did malaria microscopy, which showed malaria parasites, and he was started on artesunate. While at the clinic, he further deteriorated. Dyspnea was worsening, and the restlessness was worsening, and so they quickly rushed him to us in Chirudu National Referral Hospital for further management. While at Chirudu National Referral Hospital, we asked about urine output, and the attendants told us that this patient had been catheterized at the private clinic, and over 24 hours, they noticed that the urine was still little. The urine was dark in color. There was no body swelling, no hematuria. When you reviewed other systems, there was nothing remarkable. This was his index admission. In the past, they didn't report any admission. And his HIV is seronegative. There's no history of chronic illnesses like diabetes or asthma. He didn't report any history of steroid use. There was no history of using herbal medication. And he had not traveled recently outside this country or within the country to malaria endemic areas. There was no history of trauma as well. He's the third born of 5. His parents died of unknown causes, and he was being taken care of by the siblings. Now, having stopped for medication in P7, he was now working at the family farm, and he was spending most of his time there. And the attendants reported that he uses an insecticide-treated mosquito net. Neither smokes nor drinks alcohol. So in summary, I've presented a 17-year-old male who came with a 1 week history of fever associated with chills and rigors, with worsening difficulty breathing and cough. 2 days prior to admission, he developed headache and altered mentation, and the attendants reported that he had reduced urine output. However, there was no body swelling. And we also noted that he had been diagnosed with malaria in the private clinic. So at that point, we thought that this patient had severe malaria in view of the fever and altered mentation, and having had a positive PS at the private clinic. We also thought that the patient could have got severe community-acquired pneumonia because of fever, worsening dyspnea, and cough. And then, given that multiple systems were involved, CNS involvement, the lungs, the kidneys, we thought that this could be sepsis with multiple foci. And then we couldn't rule out meningoencephalitis at that point. We also thought about it because of fever. Again, there was headache and altered mentation. So we went ahead to examine this patient. He was a young male in severe respiratory distress. He was restless, well-nourished, febrile. However, there was no pallor of the mucous membranes. There was no jaundice, and there were no palpable lymph nodes. In the vitals, as you can notice, he was tachypneic at 32 cycles per minute, and by the time I saw him, I was already on 15 liters of oxygen by 900 breather mask. He was tachycardic at 122 with a normal BP of 130/80. Significantly in the respiratory system, he had a dull percussion note, and bronchial breathing in the right infraxillary and subscapular regions. And in all other zones, there were no more bronchovesicular breath sounds heard. In the central nervous system, significantly, his GCS was at 13/15. The other findings were normal in that system. Then in the cardiovascular system, significantly, he had a tachycardia of 120 with a regular pulse, normal volume, and the extremities were warm. BP was 130/80, and the JVP was not raised. So per abdomen was also unremarkable, but significantly when we checked in the urethral bag, in the urinary bag, there were about 300 mils of tea-colored urine. So the team thought that this again is sepsis associated with AKI, because the patient met the criteria, the QSOFA criteria, where there was altered mentation and a tachypnea of 32. And we thought that this sepsis was associated with AKI culture as expressed by the reduced urine output. We also thought that it could be respiratory distress syndrome because this patient was desaturating. We also thought of encephalopathy at that point. Also, we thought that he had right lower lobar pneumonia complicated by impending respiratory failure, severe malaria, and meningoencephalitis. So we did some baseline investigations. Maybe to note at this point is that while in Chirudu, we were only able to do the BS, which was positive, and a CBC which showed a leukocytosis with a neutrophilia. So because of the patient desaturating, we quickly contacted ICU, and the patient was taken over by the ICU team, and that's where most of the baseline investigations were done. They did a chest X-ray, which is here. It showed a consolidation, again in the right lower lobe. We did renal function test with a creatinine of 1580, urea of 44.6. The urea creatinine ratio was 7:1. Yeah, these were the liver function tests which were elevated. The liver enzymes, ALT and ST were elevated, but bilirubin, direct and total were normal. Now, they also did a urinalysis that was dark brown, turbid, with blood on dipstick. It was 3+. But significantly on urinalysis also they found there were yeast cells in the urine. Then a blood culture after 5 days still there was no bacterial growth. But when they did the tracheoaspirate, this again was in ICU, they isolated Candida species. So these were some of the findings, the chest X-ray that was done. This was the report from the tracheoaspirate where they isolated Candida species. The urinalysis also they found some yeast cells. And then this shows the blood culture that was initially done at admission. There was no growth. However, when they did another blood culture, a few days later, they isolated Enterococcus. So the final working diagnosis was sepsis complicated by AKI, right lower lobar pneumonia, severe malaria, and presumptively they thought the patient could also have had pyrroencephalitis. So at emergency in Chirudu, he was put on oxygen, started IV ceftriaxone and azithromycin, and IV artesunate was continued. And then he started him on IV fluids, normal saline, 30 mils per kilogram over 3 hours. They were to reassess thereafter. And the patient was transferred to ICU, where he was intubated and put on mechanical ventilation. While at ICU, they changed the antibiotics and included metronidazole and clindamycin. And the results delayed to come. They came 2 days later, and that's when they noticed the patient had uremia, had hyperkalemia, which were managed. And here, the picture is not clear, but the patient had uremic frost significantly. And then, as the days went on, this patient spent 14 days in ICU. The BPs kept on fluctuating. Potassium kept high, and the uremia also kept high. He got 2 cardiac arrests with return on spontaneous circulation. However, when he got the 3rd one, he passed. that's the discussion we had today. I don't know if there are any questions. Thank you for listening.